Good morning, everybody from Cologne. I'm happy to see that you've decided to join the W&H supported webinar with the title Aerosol in Prophylaxis, a Danger for the Dental Team. My name is Georg Gaßmann. I am a periodontist and the head of the Bachelor Study Program Dental Hygiene and Prevention Management at the European University of Applied Sciences here in Cologne. I'm IDR member and a DG Paro specialist, and the DG Paro is the Scientific Periodontal Society here in Germany. Let me shortly introduce the team that is supporting me. There is first Julia Haas. She's a dental hygienist and she studied dental hygiene and prevention management here in our University of Applied Sciences. My next colleague is Professor Dr. Julia Blank. She's an oral surgeon and just like me, she's also a DG Paro specialist in periodontology. Then we have Professor Dr. Hana. He's Master of Science in Periodontology and a specialist and a DG Paro specialist in periodontology too. And last but not least, there is Dr. Markus Fussenegger. He is a dentist, prosthodontist and CMD specialist and a psychological consultant. So this was the situation before Corona. We see everything's quite easy, and with the Corona situation, the situation of course has completely changed, and we can see here some safety equipment which is much more complex than it used to be. So the questions arising with the COVID-19 disease: what are the sources of infection during dental treatment? Which instruments cause aerosol? And which preventive measures can be taken when handling the aerosols? Which alternative treatment options, such as hand instrumentation and rotary polishing, are favourable? And what is the new normal in the dental practice after Corona? Answering the questions, we are going through some definitions. We will, of course, look for the infection sources. We will look at the causative microbes that might be continued in the aerosol. And we are looking at the aerosol creating treatment procedures. And then later on we will think about the preventive procedures in dealing with the aerosols. We are looking for alternatives to aerosol creating procedures, and we will take a look at the actual recommendations from different national societies to then get in the final discussion. First, let's come to the definition. SARS-CoV-2 is an abbreviation for the severe acute respiratory syndrome coronavirus 2. And it is a very infectious novel coronavirus. That's why it was called in the beginning 2019 nCoV. And this is the animal that has transmitted the virus to the humans. That's why we call it a zoonotic virus. It's the so-called horseshoe bat or Rhinolophus sinicus. And the virus that has been transmitted is the SARS-CoV-2 virus, causing COVID-19, which again is an abbreviation for coronavirus infection disease caused by SARS-CoV-2. And the transmission ways between men are mainly direct contact and droplet transmission, including aerosol. What is aerosol? Aerosol is a suspension of heterogeneous mixture of fluid and solid particles with a diameter less than 50 micrometers. And it is viable and it may contain viable and dead microorganisms within a gaseous medium. Then there is the spatter. It's a mixture of air and water and solid particles, and the particle size in this case is larger than 50 micrometers and may range up to millimeters, so that it is perceptible with a naked eye. Both media may contain infectious microbes, so we actually do not do any differentiation in daily practice. Bioaerosols are aerosols that may contain viable organisms. And there is the possibility of aerosol transmission when exposed to high concentration aerosol for a long time in a relatively closed environment. Aerosol is not something new that has appeared with COVID-19. Aerosol has always been around whenever we breathe or speak, and it is even more around the louder we speak or sing. Or if we got inflamed within our airways, because then the tissue is much more moistured, so that we generate more aerosol. How does the virus get into the cell? First of all, the virus has some glycoproteins on the surface, and they are called the spike proteins, and these spike proteins get into connection with the ACE2 receptor, which is the angiotensin converting enzyme receptor. And when the attachment has taken place, the membrane will involve, and the virus can enter the cell. After entering, the virus opens up and releases the RNA into the cytosol, which finds its way to the nucleus where it is replicated. Furthermore, the proteins that are needed to reassemble the virus are created at the ribosomes, so that in a self-assembling process in the Golgi apparatus, the virus is assembled. After the assembling, the virus will leave the cell via exocytosis and now can infect further cells. Some quick facts about the disease. Last week, when we had this webinar for the first time, the number here was 7,600,000, and we can see that it is still constantly rising, up to 9,359,818 today in the morning. There are total critical cases, 58,013, and the total deceased people who have died, the number now is 479,880. Total active at the moment are 3,873,816, and the total recovered people that do not any longer suffer from the disease is 4,840,465. So which cells may get infected via the SARS-CoV-2 angiotensin converting enzyme ACE2 receptor interaction? First of all, as we all know, the pulmonary cells, but there are also extrapulmonary cells that carry the angiotensin converting enzyme receptor, such as cardiac cells, renal cells, intestinal cells, and the endothelial cells, leading to systemic vasculitis, thromboembolism, and disseminated intravascular coagulation. Also, neuronal cells may be affected, leading to the lack of tasting and smelling sense. So this is the situation on the whole world. The darker blue, the countries are painted, the more deceased people or infected people may be found in these countries. So do we have to wait for vaccination before continuing a dental prophylaxis? Let's come back to the questions already raised in the beginning. What are the sources of infection during dental treatment? First of all, there is the dental unit, the cooling water contamination within the dental unit water lines. And then, of course, there's the oral cavity of the patient and, of course, also of the staff that may contain saliva, blood, biofilm, food debris, and restorative materials that may be contaminated with a virus. And there are, of course, the upper and the lower airways that generate the aerosol leaving the patient's mouth. It leaves the mouth while we are breathing, and when we are normally breathing, we can see that the aerosol is spread in a distance up to 1.5 meters, and this is the reason why we are asked to keep distance at least 1.5 meters in public places and also in the working field. Coughing brings the aerosol to a distance of approximately 2 meters, and sneezing is a process with very high velocity. The aerosol leaves the patient's nose and mouth with a velocity of 50 meters per second and thus may reach up to 6 meters. And within these aerosol we find microbes, and Zemuri et al. Have tested the environment of dental practices and healthcare centers, and of course they found all these different bacteria that we also know from the biofilm, from the periodontal biofilm, but we also find bacteria that may be contained in the water pipe systems of the dental units. So which instruments cause aerosol and which preventive measures can be taken when handling the aerosols? First of all, we look at the preventive measures or the measures that are used in prevention. We have the ultrasonic devices, we have the air scaler, the air polishing and the laser that are working with aerosols or creating aerosols. The patient triage is one of the most important thing according to the EFP recommendation, and in this patient triage we are asking the following questions. Do you, to your knowledge, currently have COVID-19? Have you previously been infected by the SARS-CoV-2 virus? If yes, have you been declared healed from COVID-19 clinically or have tested negative with a nasopharyngeal swab? And to this nasopharyngeal swab we have to say that actually it has been shown that it is not necessary to use the nasopharyngeal swab. We can also ask the question, the patient to collect the saliva himself from deep and from the mouth and to spit it into a glass so that the process is much less dangerous than taking the specimen with a nasopharyngeal swab. Do you currently have any of the following symptoms? Fever, cough, respiratory difficulty, conjunctivitis, diarrhea, flu, lack of smell and taste? And in the past month, have you had any of the following symptoms like fever, cough, respiratory difficulty, conjunctivitis, diarrhea, flu, lack of smell and taste? Did you have any contact with SARS-CoV-2 infected patients in the last month? Did you have any contact with subjects placed in quarantine, either self-imposed or organized by the health authorities in the last month? Did you have any contact with subjects coming from highly epidemic regions in the last month? Are you a healthcare worker? If yes, what is your job? According to the patient risk profile assessment and his needs, the clinical agenda and the waiting list is organized. When the patient arrives at the dental office, we have to measure the temperature with a contactless thermometer, while we have to say that there is low evidence for helpfulness because we cannot discover the patient's with infection without symptoms. The patient then has to remove the bag and the mobile and the coats, and hand washing with 60-degree warm water and soap is obligatory, or hand rubbing with hydroalcoholic solution. We have to repeat the office triage, and if the triage is okay, patients wearing masks take a seat, leaving at least 1 to 2 meters distance between each other. We may also organize that only one patient is in the waiting room while we have these corona times. Then the patient puts on shoe covers before going to the treatment, and the clinical staff preparation looks like following. Also hand washing with soap and 60-degree warm water, which would mean 150-degree Fahrenheit, or hand rubbing with hydroalcoholic solution. Then we put on the gloves, the first pair, and put on the gown or a jumpsuit. Then we put on the cap, and we put on the FFP2 or FFP3 mark without valve, or the FFP2 or 3 with valve, and a surgical mask. Then we put on the goggles and probably the shields, and we put on a second pair of gloves. This is a former student of our study program here in Cologne, and she's working in southern Germany, and she and her boss have decided that if they are working with aerosol creating procedures, she has to wear this high standard personal protection equipment, and as we can see, she looks quite happy that her boss has made this investment. But we can also see there is some climate up here, because in summer it may be less comfortable to work in a high standard personal protection equipment like this. And if we ask ourselves, is there any evidence for one or the other measure, the College of General Dentistry and the FGDP have made the following statements. There is very little high-quality peer-reviewed evidence, such as systemic reviews, meta-analysis, or randomized controlled trials, either to support or to contradict some of our recommendations. There is no shortage, nevertheless, of opinion being expressed in print, along with studies that lack the rigor of peer review. Such poorly founded evidence can spread quickly without much challenge. And furthermore, it is important to be wary of any claim of evidence for one approach or another, particularly when the outcome associated with a specific risk might be catastrophic. Every day we learn more about COVID-19, but all evidence needs to be clearly and carefully appraised before it is relied upon. So when we come to patient treatment, the patient should rinse with 1% hydrogen peroxide and with 0.2% chlorhexidine, each for 1 minute. Don't mix it, because then you will lower the concentration. So why do we now have to use hydrogen peroxide? It's due to a publication that was that came up in March 2020 by Comfortall, and because this tabella is too small to look into the detail, I have highlighted the interesting lines, and here we can see that this publication was about inactivation of coronaviruses by different types of biocidal agents in suspension tests. So it's not about rinsing, it's about biocidal agents on surfaces. And there, ethanol in 80% has shown to be very effective within 30 seconds to lower the concentration of the bacteria significantly. Chlorhexidine was used in a very, very low concentration, tenfold lower than we are using it in the mouth, and it has shown to be not effective. Sodium hypochlorite was very effective in 30 seconds too, and such was hydrogen peroxide in a concentration of 0.5% when it was used for 1 minute. So why do we use it with 1% in the mouth? It's because we lower the concentration, of course, with the saliva that we carry in our mouth. Povidone iodine has also shown to be very effective in concentrations between 0.23 up to 1%. It's included, therefore, in the WHO list of essential medicines. It has a very high potency for virucidal activity and an outstanding safety and tolerability, and povidone iodine mouthwashes and gargles significantly reduce viral load in the oral cavity and the oral pharynx. So after rinsing, we should avoid as much as possible aerosol. We possibly use decontaminating spray cooling with either 1% hydrogen peroxide or 0.2 chlorhexidine. The W&H tools can be used with these two decontaminating sprays. A very important point is that we have to use high power suction. So normally the prophylaxis assistants, they work with a saliva ejector. This must be changed definitely in this situation. If aerosol production is inevitable, at least try to limit it. And possibly use patient aerosol shields, as we can see on this picture. But we have to say that there are no publications that really say on an evidence-based basis that this really helps us out. So after treatment, ventilation with the open window or windows is very important, and it would be even better if we create draft by opening windows that are in opposing walls. And then we have to disinfect the environment with sodium hypochlorite, hydrogen peroxide or alcohol. The stuff after the treatment removes the gloves and the gown, and it removes the goggles and the shields, removes the mask, the cap, the second or first pair of gloves that had been taken on, and hand washing with soap and 60-degree warm water or hand rubbing with hydroalcoholic solution. Of course, there are further treatments that may create aerosol, so tooth preparation or removal of restorations using high-speed rotating burrs with water cooling, especially with turbines. Only use handpieces with anti-retraction valves. These retraction valves are nowadays in all tools of W&H and also other companies. The multifunctional syringe should be used with care, and the air scaler, as we have mentioned, and ultrasonic instruments and air polishing. And of course, the dental laser water cooling plays a role too. So the personal protective equipment should be put on if we are working with aerosol creating procedures. We should reduce the microbial load within the aerosol by letting the patient use the antiseptic mouthwash before treatment, antiseptic agent within the cooling media, and using rubber dam and tooth surface disinfection. Correct processing and periodic dental unit water system maintenance should be mandatorily carried out. And the aerosol reduction is to be achieved by effective suction technique. Suction unit should be able to do a suction volume of 300 liters per minute. And the suction cannula should therefore have a sufficient diameter of 12 millimeters, probably for hand dentistry, or maybe not only probably for hand dentistry in times of corona. The suction technique is illustrated on the following pictures that have been taken in the private practice of Professor Hahner, and thank you very much for the pictures. We can see here that we have to get very close with a suction tool into the near of the aerosol creating procedure, but we should not go directly to the instrument tip, because the cooling water, of course, is needed to cool down the instrument. So always make sure that you have the tooth in between the suction and the aerosol creating procedure. Here the other way round, when we are working from inside the mouth, the suction should be outside in the vestibule. How can we make the irrigation more effective? Reddy et al. Have made this investigation comparing a chlorhexidine with water and with a chlorhexidine that had been warmed up to 45 degrees. And we can see here, pre-procedural and after the procedure, the also water rinsing helps a little bit, but is not very effective. It is chlorhexidine which is much more effective, and the effectiveness of chlorhexidine can be even raised if heated up to 45 degrees, so that we can say chlorhexidine heating to 45 degrees could be a measure to make procedural rinsing more effective. And if we compare it with herbal extracts, as Gupta et al. Have done it, we can see that chlorhexidine again is the most effective rinsing liquid that we should use to reduce the bacterial load on the doctor's chest, on the patient chest, and on the assistant chest. So that we can say again, pre-procedural chlorhexidine irrigation before ultrasonic scaling has shown to be more effective than herbal extracts or water in reducing the colony forming units. In this publication from Graz et al., dating back to 2014, different ultrasonic devices were compared to the air scaler, and high suction cannula was compared with a conventional saliva ejector, and it was also looked at the working field, subgingival or supragingival. And as we can see here, we have the vector, we have the T-gun, and we have the air scaler. The air scaler is the procedure with the most aerosol creating procedure, and the supragingival instrumentation is always connected with more aerosol than the subgingival instrumentation. And we have even more aerosol in the surrounding if we are using the saliva injector compared to the high volume suction with the standard suction cannula. So we have the highest contamination with the air scaler, we have the highest contamination when using the saliva ejector, and the best results in the combination of piezoelectric devices and high volume suction. Something that is also decisive is the position of the treatment person in relation to the patient. It has been shown that the 12 o'clock position, which is the most favored position of two-hand dentistry, is the most contaminating position, especially when we are using the air scaler compared to the spatter that we see using the piezoelectric devices. So preventive measures, less spatter when using piezoelectric devices instead of the air scalers. When using high volume suction, and the position of the treatment person should be between 8 and 10 o'clock. Which alternative treatment options, such as hand instrumentation and rotary polishing, are favorable? There we have the treatment of stage 1 and 3 periodontitis, EFP, guideline dating back to May 2020, so it's very actual. And of course it is recommended that in the first phase of periodontal treatment the plaque removal should be done, and control of retentive factors such as part of the first step of therapy. But nothing is said how we should do it. And then we have the recommendation that subgingival periodontal instrumentation is performed with hand or powered instruments, either alone or in combination. Though that we may say that in times of corona, trying to avoid the aerosol, we should think about hand instrumentation again. And for the maintenance, we suggest performing routine professional mechanical plaque removal to limit the rate of tooth loss and provide periodontal stability and improvement as part of supportive periodontal care program. So again, no favoring of any method for biofilm removal. So that we might think about polishing again. But do we really polish when we say that we are polishing? Polishing actually means smoothing the surface, and the surface refinement by molecular surface agglomeration, and this surface refinement needs high speed generated heat. And this is not what we are doing on the tooth, of course, because the pulp can only withstand 2.2 degrees Celsius or 4 degrees Fahrenheit temperature raisal without damage. This is what we always already know since 1965. So what we're doing on the natural teeth, of course, is not polishing as the dental technicians are doing to achieve smoothened surfaces, but what we are doing is we are applying a thin layer of polishing paste, or better say prophylaxis paste, on the tooth, filling up the gaps and the grooves that we naturally find on the tooth surface or that we may find due to tooth wear, so that the patient after the polishing process has the feeling of a smoothened surface. But of course for a completely other reason than polishing and what dental technicians do. So to measure whether there is really a decisive loss of enamel due to polishing, Pence et al. Have used these experimental setting to check whether polishing with 2,500 rounds per minute and a pressure of 150 grams over a time of 5 seconds would lead to enamel loss. So they imitated repetitive coronal polishing, and they did it 5 seconds per surface and 50 times on the buccal surface in order to imitate or to simulate a semi-annual polishing in a 75-year-old patient that had the diagnosis of periodontitis at the age of 50. For the procedures, 16 extracted premolars and 32 third molars were used. and there was a significant difference between test and control, test meaning that no polishing was performed, and the standard error was to be attributed to the plus minus micrometer limitation of the measurement accuracy. The mean difference that we were talking about up here was 20 micrometers plus minus 3.9. And into relation to that, we have to know that the minimal enamel thickness to be measured at 0. millimeters coronal to the cementum enamel junction is 81 micrometers plus minus 8.07. So we have 20 micrometers in relation to 81 micrometers, so that we still have 61 micrometers of enamel in this very apical position of the enamel. So that we can say that there is no danger for exposing dentin by polishing. This is a little bit different on restoration materials. Roulet and Roulet-Merens have made this publication back in 1982 already, and here we can see a surface that has been polished using aluminium coated flexible discs, the so-called Soflex, and we see a very smooth surface after polishing this way. This changes completely if we do polishing with a rubber cup and a polishing paste for 30 seconds. Here we can see that the soft matrix of the composite has been polished out and that the mineral particles are now leaping out of the matrix. And we can even worse it if we use a soft brush with a polishing paste for 30 more seconds. Then we can see that we have a really rough surface on the composite surface after polishing. So do no polishing on restoration materials. What we are aiming at is the biofilm destruction. So in corona times, rotary polishing can or should be favored. And we get some help from W&H with a Proxio twist latch short polishing system, and we can directly see that we have a much smaller building height here at the Proxio twist latch short polishing system than we normally have with a handpiece. And in situ we can see that it's much easier to reach into the spaces where we normally have some problems to get in, and we can further see that the sharp edge of the rubber cup may leave some trauma on the soft tissue of the cheek or the lip if we are not absolutely carefully, and this cannot happen here because we have a direct connection between the handpiece head and the rubber cup. We get even more of some flexibility if we use the cordless system, and we can see that the handpiece and the foot control are without cables, so that we have extreme flexibility. For instance, also if we think about using it not in the dental practice setting, but maybe in older care people, in homes for older people care. And what we can see here is that the rubber cups have a very special surface. They may retain tightly the prophylaxis paste so that it is not spread in the surroundings when we are using it at the patient. The lamella inside the rubber cup, they retain the prophylaxis paste so that when we are polishing the tooth surface for 5 seconds with a maximum speed of 800 rounds per minute, because we do not want to cook the pulp, and then we can sufficiently remove the biofilm from the tooth surface in 5 seconds. So why should we still use prophylaxis pastes? Of course, because of the ingredients. There are different stannous junctions against halitosis, caries, gingivitis and hypersensibilities. And we have chlorhexidine against bacterial recolonization and different enamel strengthening and antibacterial fluoride connections. And the formulations based on casein, mineral and arginine are helpful in caries, erosion and hypersensibility prophylaxis. So please continue with prophylaxis also in times of corona. Our patients are not in our practice 363 days a year, so it's decisive what they are doing at home all the time. And do please not demonstrate brushing techniques on the models. It has definitely been shown not to be helpful. So we have evidence that it does not help the patient if we demonstrate toothbrushing on the model. Do it on the patient, and as a even more important point, let the patient do it himself or herself in front of your eyes, so that you are sure that the patient can carry out the brushing technique or whatever you have demonstrated to carry it out at home sufficiently. So what is the new normal in the dental practice while and after corona? And aerosol in prophylaxis, is it a danger for the dental team? The most important thing is applying the patient triage. Oral health is a decisive factor in keeping systemic health, preventing from any kind of infection. So we have to take care that our patients are kept healthy in the mouth in order to prevent any kind of infection. Therefore, dental prophylaxis is still inevitable. Stick to the standard health precautions as we in our dental profession are utmost used to and have proven to be effective. Stick to your national and regional precaution instructions and use pre-procedural rinsing with 1% hydrogen peroxide and 0.2% chlorhexidine. Chlorhexidine warming up to 45 degrees has proven to be more effective in reducing colony-forming units caused by the aerosol. And another very important point is use high-volume suction with an effective technique. Avoid aerosol creating procedures and favor scaling and rotary polishing. Use high standard precautions in case of questionability of COVID-19 infection. We have a competent scientific research system providing new helpful instructions. Get informed and stick to them apart from the instructions given in this presentation due to the present available knowledge. So thank you very much for your interest. I am now open for your questions, and I will go back to the final points so that you might get some inspiration for your questions. Oops. So thank you very much for all the greetings that have come from the Philippines and from Egypt and from Vietnam, from Saigon, and from Adelaide in Australia, and from the Philippines. It's really amazing how many people from so many countries are watching the webinar. So if there is no question at the moment, I would again like to point out that the oral health is a very decisive factor in this theme, because it is really questionable whether only the lung cells are involved in the infection with the coronavirus, because a lot of other cells have also shown these receptors where the spike protein of the virus is adhering to. And like this, it really makes sense that before treating the patients, we should ask them to rinse with hydrogen peroxide in a 1% concentration, and of course also still with chlorhexidine, because there are a lot of other diseases that may be spread by the aerosol. Just because we have COVID-19 at the moment, still the other diseases that may be transmitted still exist, and oral health is a very important point. That helps us keep the systemic health, and it is really very questionable that in Germany the government has decided that the dental field is of lower interest compared to other medical professions. Thank you from Australia. And a lot of thank yous, but but no questions. And furthermore, I think it is very important, apart from the instructions that I gave in this presentation, you really have to stick to the national and regional precaution rules that are given by your government, because it is also a forensic problem that if you do not stick to them, you may later on get some law problems. So really make sure that you have all the instructions that you need, and try to apply them to your dental practice. And something which is also very important is that you are training your team, because your team, you have the responsibility for your team, and of course you can only convert the rules into your practice if the staff that you have is working together with you. There has been some discussion about the 1% hydrogen peroxide, that it may be cancerogenious. Yes, of course, it may be cancerogenious, but not if we use it when the patient comes to the dental office. We, of course, do not recommend that the patient should do it at home every day, maybe twice a day, of course not. And only in such a case this would be decisive, so that as a precaution in times of COVID-19, I think we can really use it for the protection of ourselves and our staff. And I think it's also a very good idea to warm up the chlorhexidine. I'm really waiting for some publication using the concentration of chlorhexidine that we are actually using, either 0.12% or 0.2%. I think this is really necessary to know whether we really have to continue using 1% hydrogen peroxide additionally to chlorhexidine. I can imagine that if we use chlorhexidine in a high concentration, it might be more effective. So, a lot of greetings, but no questions. So that I would say I was very happy to be here with you this morning, and for you maybe it was the afternoon or already the evening. And I think we are really in a difficult time, and also for myself it was good to prepare this presentation because we have to be really informed, and we have to stay informed, because as we've heard we are learning more and more about COVID-19 every day, so that we really have to look at the news or into the scientific publications